Welcome to Chapter 9, Part 2. This one will be a little bit more simple compared to Part 1. We're just going to look at how bones act as levers because this will make more sense when we talk about muscle contraction if you know a little bit about bone structure and how they act as levers. And then the second half, we're going to talk about some common joint structures. There's some words that we need to focus on when we talk about a lever, which is an elongated, rigid object. We're going to talk about some fixed point or fulcrum. And we're going to talk about the effort being applied and the resistance at some other point. Here we have a first-class lever system. And basically the fulcrum is in the middle, and the fulcrum is always going to be your joint. And the effort is usually going to be delivered by some sort of muscle. So here in our atlanto-occipital joint of the neck, we have the atlas, which is your first vertebrae, and we have the occipital bone here. The fulcrum point is this joint between these two articulated bones. And we can see that as this muscle contracts, that the resistance decreases and you're able to lift your chin. Here we have a second-class lever system. You can see the fulcrum has been shifted from the center to in front of the resistance. This is rare in the body, but it does allow for a small amount of force to lift a larger weight. And we see this example in the human body if you're standing on your tippy toe or doing plantar flexion. So the fulcrum here is the joint between the metatarsals and the phalanges. And we're contracting these muscles, which give us the effort, and we're able to lift the load, which is our heel, off the ground. Here we have a third-class lever system, and this is most commonly used in the body. We can see that the fulcrum has been shifted behind the effort and the resistance. For a human body example, we can see the fulcrum here, and this is our elbow joint. That's the pivot point, right? And we can see that the muscles are going to contract and generate the effort. But I want you to pay close attention to the attachment points. So we have one attachment point here, and we have one attachment point here for biceps brachii. So you can see that if the muscle wasn't attached here at the lower radial tuberosity, when this muscle contracts and pulls together, it lifts the load, but only because of the attachment points of the muscles. So what should you take away from these last three slides? So your skeletal system, your bones act as levers. Your joints act as the fulcrum, the pivot point, right? How do we get effort? What's the effort? We get this from muscle action. And what is the resistance? When we say resistance, we're talking about load to be lifted. So you can see we're kind of setting you up for how the muscles are going to attach to the bones and then how the muscle contraction actually causes movement within the body. Now we move on to talk about the different joints. So here we have TMJ, Temporomandibular Joint. Remember that the fossa, the mandibular fossa of the temporal bone, articulates to the mandibular condyle of the mandible. Here's the joint cavity, and I want you to see that the articular capsule, that fibrous tissue, is not as thick in this joint. And the reason for that is we want to have more flexibility. So remember, kind of, if we have less structure, we have more flexibility. So remember, we can do depression, elevation, we can do protraction, retraction. So the ability to move our jaw in various ways is because of the structure of this joint. The other thing to notice is this articular disc. It's basically fibrocartilage that separates the joint cavity. So you actually have two joints here, not just one, but we refer to it as TMJ. TMJ disorders are when that articular disc gets forced out of normal position. And when that happens, you'll hear a clicking or a popping noise. This can happen if you're someone that clenches your teeth while you're sleeping, or if you chew gum excessively. And one of the things that's interesting is that the pain can be felt in various areas because of the trigeminal nerve. And we won't get to this until we talk about cranial nerves in Unit 4, but there are several points that this trigeminal nerve feeds or innervates, and so sometimes the pain is felt over all of the areas. It's kind of like a spreading out, and your brain can't exactly tell where that pain came from. So the trigeminal nerve innervates the maxilla and the mandible and part of the face. Here we have sternoclavicular joint. We have the clavicle and the sternum articulation. Again, we have an articular disc. Again, we have articular capsule that's really thin. So when you see thin articular capsule, you should be thinking increased flexibility. And this joint allows us to do the elevation and depression of our pectoral girdle, and then also allows us to do circumduction. We previously talked about the glenohumeral joint, so where the head of the humerus fits into the glenoid cavity of the scapula. Remember, we had lots of bursa, we have tendon sheaths, we have lots of ligaments because we're holding the clavicle, right, to the scapula, and then the scapula to the humerus. So there's kind of a lot going on in this image here. Here's another view of the glenohumeral joint. We saw this in part 1, but I wanted to focus on the fact that here's the glenoid cavity, here's the head of the humerus, and I wanted you to see that this is a pretty shallow ball and socket joint. So this is a ball and socket synovial joint, but it's pretty shallow. So often if the arm is extended and you have impact on the shoulder, you can very easily dislocate the humerus from the glenoid cavity. I did want to add that this glenohumeral joint has lots of ligaments that are offering support, and then we also have tendons from these rotator cuff muscles. So we'll talk more about muscles later, but I kind of wanted to make sure you understand the connection between muscle tension. So muscles that are being worked out, muscles that have a little bit of muscle tension even at rest, because those tendons fuse with the articular capsule, they're providing joint stability. Now we move on to the elbow joint. This is a hinge joint. Remember, we can do flexion, but we cannot do hyperextension at the elbow. So no hyper. Flexion, yes. This is actually two joints, but what's interesting is that they're both enclosed in a single articular capsule. Another view of this joint, this elbow joint, I want to make sure that we have the radius and the ulna and the humerus. If you remember, the humerus has the trochlea, and then over here it also has the capitulum. The trochlea and the trochlear notch of the ulna articulate, and the capitulum and the head of the radius articulate. The whole point of this slide is to show you that there's only one articular capsule for this joint. So it's kind of all housed together. The elbow joint is pretty stable, but we do have a dislocation that can occur when the head of the radius slips out of the capitulum of the humerus. It's kind of the weak point of this joint. So we call this a subluxation. That means incomplete dislocation. Here we have the hip joint. Sometimes it's called the acetabulofemoral, because this is your femur joint. So acetabulofemoral joint. And remember, this is the acetabulum of the coxal bone, right? And here's the head of the femur. And we also mentioned the ligament that attached at the fovea capitis of the head of the femur. This is a much more stable joint. If you were to see these bones in class, you would see that much more of the head of the femur fits farther into the acetabulum than the shoulder joint. So we have more stable that's going to mean less flexible. So we're kind of trading off a little bit. But remember, all of our weight from our axial skeleton is kind of being focused down on our femur. So we want this to be a really solid joint. Now we'll move on to the knee joint. This is the largest, it's the most complex. It's still diarthrotic, freely movable, but it is a hinge joint. Remember, you can't do hyperextension at the knee or the elbow. It's capable of slight rotation and a little bit of lateral movement. There are two separate articulations. So we have where the tibia and the femur meet, so the tibiofemoral joint, and then we have the patellofemoral joint. So this is where the patella or the kneecap articulates with the femur. The knee joint is very complex. Let's just look at the anterior. So on the front side, we have our four muscles, our quads, quadriceps, and we have all the tendons converging. We also have our articular capsule or joint cavity. We have here our patella. Our patella has to attach to the tibia. That's our patellar ligament. And then we also have our fibular ligament connecting the femur to the fibula. That's just the anterior view. On the posterior view, we have more ligaments. We have muscles. So we have this muscle that runs on the posterior part of the leg. We have gastrocnemius, we haven't learned yet, calf muscles. So it's kind of the convergent point, right? So you've got your femur, and then all of the weight from your body is being directed toward this knee joint, and then from the knee joint into the tibia. Now we're looking at a deep view of the knee joint. We've removed the fibrous capsule and the muscles and the tendons so that we can look at the condyles and where the condyles sit. Remember your medial and lateral condyles of your femur. And we can see that they're sitting right here on this meniscus. So the meniscus comes in two separate pieces, lateral and medial. But basically, if you remember, we gave this as an example of the fibrocartilage that acted as compression resistance. So we have here the femur, and all of the weight is bearing down through this joint structure onto the tibia. We have all of these other ligaments that are going to help stop lateral movement and then posterior and anterior movement. So we don't want any slippage here. So the meniscus is going to help with that, and then these ligaments, posterior cruciate ligament, anterior cruciate ligament. So one's in the front, one's in the back. And then we also have, if you remember, that fibular ligament, and we also have a tibial ligament. So basically trying to keep everybody in the exact location they need to be in so that there's no lateral movement or posterior and anterior movement. I'm sure when I mentioned anterior cruciate ligament and posterior cruciate ligament, if you watch football, you're probably like, oh, I know what that is, right? So we've seen these injuries if you watch sports on TV. So the ACL is the anterior, the one in the front. If your leg is hyperextended, you can cause injury or tear your ACL. PCL is if the leg is hyperflexed. So we have some movement here, but we can't have exaggerated movement or have a 300, 400 pound person land on our leg wrong, right? Also, the meniscus. This is fibrocartilage. Remember, cartilage is avascular. What do we know about avascular? It doesn't have its own blood supply, so therefore it's slow to heal. We also have these ligaments that I just talked about, the fibular and the tibial ligament. So basically, if you damage one of these, it's probably okay. But if you have multiple areas that are injured, that's going to cause problems, and it's going to take a long time to heal. Here we're looking at the talocrural joint, if you want to think of your ankle joint. But this is where the talus articulates with the tibia and the fibula. And they just say crural for lower leg, because both the fibula and the tibia articulate to the talus. So you have two bones articulating to the one ankle bone, the talus or tarsal bone. Here we have the lateral ligament, and the lateral ligament you can see is helping to support or connect the fibula with the calcaneus and the fibula with the talus. This also stops you from doing over inversion. You remember how you twist your ankle outwards and look at the bottom of your foot or sole of your foot from the inside? So this lateral ligament is what stops you from doing that too much and like flipping your entire foot upside down, right? Also, think about, we're still talking about weight distribution here, right? We're looking at the hip, and then the weight goes to the knee joint and down the tibia, and here we are at the ankle. So the talus is supporting all of your weight. Here we have a medial view so that you can see the deltoid ligament. So the deltoid ligament is helping to connect the tibia to the talus, and this deltoid ligament is also stopping you from doing too much eversion, right? For overdoing eversion or turning your foot out to look at the lateral aspect of the foot. In a clinical view, we can look at sprains. I just want to mention that sprains are stretching or tearing of ligaments. If you hear somebody say the word strain, they're usually talking about tendons. Most of us use these words interchangeably, but the T for strain, T for tendons, sprain is when you damage a ligament. And then there are some fractures that can occur. So remember, your medial malleolus is on your tibia. It's kind of that ankle bone that sticks out. So you can have a fracture there. And then also, if this talus, if one of the tarsal bones moves laterally, moves to the outside, the fibula is right there. So it can cause a fracture of the fibula. Joints start to form by about the 6th week of development. Again, these mesenchymal cells are going to differentiate and turn into either the regular connective tissue or the hyaline cartilage. The synovial joints, again, mesenchymal tissue, it's going to form the synovial membrane. So you can see that this tissue is kind of like the starting, stem cell tissue that differentiates into all of these tissue types, which are going to create the joint cavities. We can look at these different types of disorders that can occur with joints. So arthro means joint, itis means inflammation, right? So we have just kind of a general arthritis. So this is some sort of inflammatory disease of the joint. You're going to have pain and swelling and stiffness. It could be temporary, right? It might just be temporary arthritis. Then we can have gouty arthritis. This is usually seen in older males. There's increased levels of uric acid, and this can come from nucleic acid breakdown. So eating a lot of meat. Remember, nucleic acids make up DNA. So if you have more uric acid crystals, or I should say if you have more uric acid, they'll form these crystals in joint cavities. So imagine having spiky, sharp little crystals inside of a joint cavity. That would be pretty painful. And for some reason, we don't know why, these crystals kind of fall due to gravity, they kind of fall to the big toe joint. So usually if somebody's having issues walking, they might be saying, oh, my gout, right? So we can give you drugs, we can help increase fluids and help try to flush out these uric acid crystals. Next, we have osteoarthritis. So this is what I think of as old age wear and tear. So just kind of a wearing down of the articular cartilage over time. And then we have rheumatoid arthritis. This is very different. So rheumatoid arthritis is an autoimmune disorder. Basically, your immune system is attacking, let me see if I can get this out. Your immune system is attacking your joint cavity. So we don't know exactly why this happens, but your immune system doesn't recognize your joint cavity as yourself, as self cells, and it starts attacking them like they're foreign and breaking them down. So you could imagine how that would cause pain and stiffness and swelling. So I know we're all thinking, well, Miss Nikki, tell us what we can do about it. Exercise and joint health. Anything that can increase the flow of synovial fluid. If you keep the joint lubricated, you have a better chance of not having any inflammation or swelling or stagnation or pressure. If you strengthen the muscles, we keep talking about how muscle, tendon support can actually stabilize joints. keep that joint cavity firm, tight, not slipping. Extreme joint problems can worsen the normal wear and tear. So the way I look at this is if you are ignoring a joint problem, it's going to cause you to have more rapidly developing wear and tear or osteoarthritis. So one of the things I tell people to do, yoga. So gets all of your body fluid moving, gets your joints nice and lubricated. You're usually holding poses and making these joints work. You're making the muscles and the tendons support the joint while it works. So it's a really good exercise as we age to make sure our joints stay happy and healthy and flexible. So I'll talk to you guys next PowerPoint. Bye.